You may have heard about ketamine as a party drug, a horse tranquilizer, or as a psychedelic treatment that's already legal. So, what's the truth? And among the different models of ketamine therapy, which one is best? I'm Dr. Matthew Hicks, and today I'm breaking down the three primary models of ketamine treatment to help you decide which path might be right for you or someone you love. Ketamine got its start in 1962 when the Parke-Davis Pharmaceutical Company was looking for a safer alternative to the anesthetic phencyclidine, or PCP. Yes, that PCP. By 1970, the FDA had approved it for anesthesia because it suppressed pain without slowing down the heart or lungs. It was noticed early on that it had antidepressant and psychedelic effects, but this was the psychedelic 60s, psychedelics were starting to get a bad rap, and ketamine's developers didn't want to jeopardize its approval by associating it with other psychedelics. So they coined the term dissociative anesthetic to categorize it and called the psychedelic effects emergence delirium and considered it a side effect. Off-label use for psychiatric applications grew slowly until around the year 2000 when researchers at Yale published a study demonstrating that a smaller sub-anesthetic dose could lift a person out of a depression in just hours rather than weeks. More on that in a moment, but first, let's say something about how it works. Unlike traditional antidepressants that target serotonin or dopamine, ketamine works on glutamate, the brain's primary chemical messenger. Ketamine blocks a certain type of glutamate receptor, the N-methyl-D-aspartate, or NMDA, causing glutamate to build up and for these receptors to become more sensitive to it. This seems to also have a downstream effect of triggering synaptogenesis, literally growing new connections between neurons. This creates a window of neuroplasticity where your brain is briefly more flexible and able to adapt to new ways of thinking and feeling. Let's break down the three primary models of ketamine as it's used in psychiatric applications today. First, we'll talk about the IV infusion model, often called the NIMH, or National Institute of Mental Health protocol, because they developed the early version of it. It's the most researched and established psychiatric application for ketamine. This doesn't necessarily make it the best one, it just has the most research, which I'll say more about later. After a medical screening, the standard induction protocol is 6 sessions over a 2 to 3 week period. At each session, you'll receive a 40-minute infusion of racemic ketamine, I'll say more about what that means later, directly into your bloodstream, ensuring 100% bioavailability. This approach is a purely pharmacologic intervention, meaning you'll sit quietly in a chair, you'll be monitored for your vital signs in a comfortable lounge room, but there's really no psychological support. The dose is low and slow to minimize psychedelic effects, but people still have them, including sometimes challenging psychological content, such as memories of trauma that can be hard to manage without support. Because this is an off-label use, insurance rarely covers it. You can expect to pay somewhere between $400 to $800 per session out of pocket, making the initial investment of $2,400 to $4,800. Recent studies suggest IV ketamine may act faster and lead to slightly higher remission rates than Spravato. What is Spravato, you ask? If cost is a barrier, an alternative is Spravato. Approved by the FDA in 2019, Spravato is a nasal spray version of Esketamine. Regular or racemic ketamine is a 50-50% mixture of S and R ketamine, which just means that the molecule exists in two mirror-like versions of itself, just like our hands. While S-ketamine has shown stronger binding capacity to receptors, R-ketamine has shown stronger antidepressant effects in rodent studies. One study comparing effects in humans found no significant difference between the two. This is a common strategy in the pharmaceutical industry. Find a drug that works, modify it slightly, even if it doesn't change any effects or outcomes, and get a patent so you can market it as something new and make a lot of money out of it. The difference in drug costs are substantial. A single dose of generic ketamine costs around $5, while a single dose of Spravato costs nearly $800. Nonetheless, because it's FDA approved, it is routinely covered by insurance, including Medicare and Medicaid. To qualify, you must be diagnosed with treatment-resistant depression, which involves a trial and failure of one or more first-line treatments. After getting a prior authorization from your insurance, you'll go to a certified clinic under a safety program called REMS, which stands for Risk Evaluation and Mitigation Strategy. You will self-administer the spray into your nose and then stay for 2 hours of observation by the medical staff. Like the Infusion model, there is no psychological support involved. The model that I practice is called Ketamine-Assisted Psychotherapy, or CAP for short. Here, like other psychedelic therapies, the medicine isn't the whole treatment. Rather, it's considered a catalyst that opens the door for deep psychological work. The process starts with screening and preparation, where trust is established in the therapeutic relationship and your intentions are thoroughly explored. During the dosing session, which typically lasts about 2.5 to 3 hours, a therapist is with you the entire time, helping you navigate the experience. Most importantly, you have integration sessions in the days and weeks following the ketamine sessions to turn the insights you gain into lasting changes. CAP is defined by the therapeutic support that is offered, not the route of administration. I typically use intramuscular injections, while others use sublingual lozenges, infusions, or other methods. While insurance may cover the therapy hours, they rarely cover the ketamine sessions themselves. So sessions can cost $400 to $1,000 because of the therapist's time. Many find this model optimal because it offers the same physiologic benefits that the other models do, but better utilizes the neuroplastic window we spoke about earlier to address root causes, which are often psychological rather than just physiological. CAP may be particularly effective for those with a history of trauma, where having a safe human presence is a vital part of the healing process. However, research in ketamine-assisted psychotherapy is much more sparse than it is in other models, so some of this is anecdotal, and you have to take it with a grain of salt. So, which is right for you? IV infusions are best for rapid relief if you can afford the out-of-pocket cost and would rather not engage in psychotherapy. Spravato might be the best option if you meet the criteria and you need insurance coverage to seek any care. The CAP model, or ketamine-assisted psychotherapy, is my recommendation in most situations because it utilizes a holistic approach, pairing physiological benefits with deep emotional healing. Despite the various successes of these models, there is a massive gap in the science. We don't have a large-scale head-to-head study comparing these different models. So we can't prove that CAP leads to longer lasting healing than a clinical IV alone. It's left to the consumer to decide which model is best for them. That's where Synaptic Institute comes in. We are a nonprofit dedicated to conducting clinical research, providing accessible care to everyone regardless of their income level, and doing public education like this YouTube channel. We're currently raising funds for a landmark comparative study. We'll make another video about it soon, but if you want to help us move psychiatry toward a more equitable and supportive future, please click the link in the description to support our research and/or our Care Access scholarships. Together, we can find the data that will help change lives. Thanks for watching.